Good evening, Dr. Phil here. Today we'll be discussing on cranial nerve 5, the trigeminal nerve. Cranial nerve 5 emerges from the brainstem of the pons. Location of nerve cell bodies: the ophthalmic division, cranial nerve V1, from the trigeminal ganglion. For the maxillary division, cranial nerve V2, from the trigeminal ganglion. And for the mandibular division, cranial nerve V3, from the trigeminal ganglion for somatic sensory, and from the pons for somatic motor. Trigeminal nuclei. Motor nuclei is the motor nucleus of the trigeminal nerve. Sensory nuclei, the mesencephalic nuclei of the trigeminal nerve, primary sensory nuclei of the trigeminal nerve, and spinal nuclei of the trigeminal nerve. Cranial exit. Ophthalmic division, cranial nerve V1, exits from the superior orbital fissure. The maxillary division, cranial nerve V2, exits from the foramen rotundum. The mandibular division, cranial nerve V3, exits from the foramen ovale. General functional types of fibers. The ophthalmic division consists of somatic sensory fibers. The maxillary division consists of somatic sensory fibers. The mandibular division, cranial nerve V3, consists of somatic sensory and somatic motor fibers. Course and distribution of the trigeminal nerve. Cranial nerve 5 supply derivatives of the frontonasal process and the first pharyngeal arch. Nerve fibers emerge from the pons and travel to the trigeminal ganglion at the petrous temporal bone, and it splits into three divisions, V1, V2, and V3. The sensory root of cranial nerve 5 is composed primarily of the central processes of the pseudo-unipolar neurons that make up the sensory trigeminal ganglion. The trigeminal ganglion is flattened and crescent in shape, is also known as the semilunar ganglion, and is housed in the trigeminal cave, a dural recess lateral to the cavernous sinus. Peripheral processes of the ganglionic neurons form three divisions as mentioned. The ophthalmic division. Cranial nerve V1 passes through the superior orbital fissure to reach the orbit. It serves structures derived from the paraaxial mesoderm of the embryonic frontonasal process. Branches of the ophthalmic nerve includes the tentorial nerve, which is a meningeal branch, the lacrimal nerve, which further branches into the communicating branch from the zygomatic nerve, the frontal nerve, which further branches to the supraorbital and supratrochlear nerves, nasociliary nerve, which further branches into the sensory root of the ciliary ganglion, short ciliary nerves, long ciliary nerves, anterior and posterior ethmoidal nerves, and infratrochlear nerves. Next, the maxillary division, cranial nerve V2. This branch passes through the foramen rotundum to enter the pterygopalatine fossa. This fossa is a small space in the deep face in the shape of an inverted pyramid located between the maxillary bone anteriorly, the pterygoid process posteriorly, and the orbital apex superiorly. Significance of the pterygopalatine fossa: it's the neurovascular crossroad of the nasal cavity, masticator space, orbit, oral cavity, and middle cranial fossa. It's an important pathway for the spread of neoplastic and infectious processes. It's often infiltrated with local anesthetic to provide a maxillary nerve block for oral and maxillofacial surgery. Loss of sensation to the maxillary sinus, upper molars, canines, and incisor teeth, the cheek, and the gums occurs. Contents of the pterygopalatine fossa includes the pterygopalatine ganglion, descending palatine artery, which is a branch of the maxillary artery, the maxillary nerve, cranial nerve V2, and the nerve of the pterygoid canal. The maxillary nerve innervates derivatives of the maxillary prominence of the first pharyngeal arch. Branches of cranial nerve V2 includes the meningeal branch, zygomatic nerve, which further branches into the zygomaticofacial branch, zygomaticotemporal branch, and communicating branch to the lacrimal nerve. Ganglionic branches to the sensory root of the pterygopalatine ganglion. Posterior superior alveolar branches. The infraorbital nerve, which further branches into the anterior and middle superior alveolar branches, superior labial branches, inferior palpebral branches, and external nasal branches. The greater palatine nerves, which further branches into the posterior inferior lateral nasal nerves. The lesser palatine nerves, posterior superior lateral nasal branches, nasopalatine nerve, and pharyngeal nerve. Next, we move on to the mandibular division, cranial nerve V3. The mandibular nerve passes through the foramen ovale to enter the infratemporal fossa. It innervates derivatives of the mandibular prominence of the first pharyngeal arch. Fibers of the motor root of cranial nerve 5 passes inferior to the trigeminal ganglion along the floor of the trigeminal cave. They bypass the trigeminal ganglion and are distributed exclusively via cranial nerve V3. It blends with the sensory fibers as the nerve passes through the foramen ovale. Branches of cranial nerve V3. Somatic sensory branches includes the meningeal branch, nervus spinosum, buccal nerve, auriculotemporal nerve, lingual nerve, the inferior alveolar nerve, which further branches into the inferior dental plexus, and mental nerve. Somatic motor branches of cranial nerve V3 includes the mesenteric nerve, deep temporal nerves, nerve to the medial and lateral pterygoid, nerve to the mylohyoid and anterior belly of the digastric, nerve to the tensor villi palatini, and nerve to the tensor tympani. Main actions of the trigeminal nerve. The ophthalmic division receives sensation from the anterior scalp, skin of the forehead, anterior and supratentorial dura mater, superior eyelid, cornea, superior conjunctiva, skin of the dorsum of the external nose, mucosa of the anterior superior nasal cavity, and mucosa of the paranasal sinuses, frontal ethmoidal and sphenoidal sinuses. The maxillary division receives sensation from the dura mater of the anterior part of the middle cranial fossa, the inferior eyelid, conjunctiva of the inferior eyelid, skin of the lateral external nose, mucosa of the posterior inferior nasal cavity, skin of the face over the maxilla, maxillary sinuses, upper lip, maxillary teeth, anterior part of the superior oral vestibule, and the palate. The mandibular branch receives sensation from the skin of the face overlying the buccal, parotid, and temporal regions, the external ear, which includes the auricle, upper external acoustic meatus, and tympanic membrane, the temporal mandibular joint, skin of the lower lip, posterior and anterior-inferior oral vestibule, mandibular teeth, mucosa of the floor of the mouth, and mucosa of the anterior two-thirds of the tongue. The mandibular division provides motor supply to the mylohyoid, anterior belly of the digastric, masseter, the temporalis, pterygoid muscles, tensor villi palatini, and tensor tympani. Parasympathetic ganglia and cranial nerve 5. Cranial nerve 5 do not convey presynaptic parasympathetic fibers. However, postsynaptic parasympathetic fibers from all 4 cranial parasympathetic ganglia joins branches of cranial nerve 5. These fibers are carried along with cranial nerve 5 sensory and motor fibers to innervate their target structures. The 4 cranial parasympathetic ganglia includes the ciliary ganglion, the pterygopalatine ganglion, the otic ganglion, and the submandibular ganglion. The ciliary ganglion is located between the optic nerve and the lateral rectus, close to the apex of the orbit. Its parasympathetic root is the inferior branch of cranial nerve 3. Sympathetic root is branches from the internal carotid plexus in the cavernous sinus. Main distribution. Parasympathetic postsynaptic fibers from the ciliary ganglion pass to the ciliary muscles and sphincter pupillae of the iris, whereas sympathetic postsynaptic fibers from the superior cervical ganglion pass to the dilator pupillae and blood vessels of the eye. The pterygopalatine ganglion, also known as the sphenopalatine ganglion, is located in the pterygopalatine fossa. This ganglion is suspended by the ganglionic branches of the maxillary nerve. This ganglion lies just anterior to the opening of the pterygoid canal and lies inferior to cranial nerve V2. Its parasympathetic root is the greater petrosal nerve from cranial nerve 7 via the nerve of the pterygoid canal. Its sympathetic root is the deep petrosal nerve, which is a branch of the internal carotid plexus, a continuation of postsynaptic fibers of the cervical sympathetic trunk. Fibers from the superior cervical ganglion pass through the pterygopalatine ganglion to enter the branches of cranial nerve V2. Main distribution of the pterygopalatine ganglion. Parasympathetic postganglionic fibers from the pterygopalatine ganglion innervates the lacrimal gland via the zygomatic branch of cranial nerve V2, whereas sympathetic postsynaptic fibers from the superior cervical ganglion accompany branches of the pterygopalatine nerve that are distributed to blood vessels of the nasal cavity, palate, and superior parts of the pharynx. Next is the otic ganglion, which is located between the tensor villi palatini and cranial nerve V3 and lies inferior to the foramen ovale. The parasympathetic root of the otic ganglion is the tympanic nerve from cranial nerve 9. This root continues from the tympanic plexus as the lesser petrosal nerve. The sympathetic root of the otic ganglion are fibers from the superior cervical ganglion that come from the plexus on the middle meningeal artery. Main distribution of the otic ganglion. Parasympathetic postsynaptic fibers from the otic ganglion are distributed to the parotid gland via the auriculotemporal nerve, a branch of cranial nerve V3. Sympathetic postsynaptic fibers from the superior cervical ganglion passes to the parotid gland to supply its blood vessels. Lastly, the submandibular ganglion. This is located on the surface of the hyoglossus. This ganglion is suspended from the lingual nerve by two ganglionic branches. The submandibular ganglion lies inferior to the submandibular duct. Its parasympathetic root are parasympathetic fibers that join cranial nerve 7 and leaves it in its cauda tympani branch. The cauda tympani branch then unites with the lingual nerve. The sympathetic root of the submandibular ganglion are sympathetic fibers from the superior cervical ganglion that travel via the plexus on the facial artery. Main distribution of the submandibular ganglion branches. Parasympathetic postsynaptic fibers from the submandibular ganglion are distributed to sublingual and submandibular glands. Sympathetic postsynaptic fibers from the submandibular ganglion supply the sublingual and submandibular glands as well. Testing of cranial nerve 5. Motor function. First, inspect for temporalis wasting. Differential diagnosis for temporalis wasting includes long-term cranial nerve 5 palsy, motor neuron disease, myotonic dystrophy, etc. Then ask the patient to clench their teeth and palpate for bulging of the masseter and temporalis muscles. The patient is then asked to open their mouth wide. If there is a cranial nerve 5 lesion, the jaw will deviate towards the site of the lesion. The patient is then asked to open their mouth and resistance is provided by holding their jaw closed with the assessor's hand to assess for muscle power. The jaw jerk. Explain to the patient the process of performing the jaw jerk and explain what is about to happen. The patient is asked to let their mouth hang loosely open. The assessor's finger is placed horizontally across the patient's chin and the finger is tapped with a patella hammer. Feel and watch the jaw movement. Normally, there should be a slight closure of the jaw, but this varies widely in normal people. If there is an upper motor neuron lesion, a brisk and definite closure may indicate an upper motor neuron lesion above the level of the pons, such as in pseudobulbar palsy. Testing of sensory function of the trigeminal nerve. Maps for cutaneous innervation for cranial nerve V1, V2, and V3 has little overlap in innervation by the divisions. Lesions of a single nerve results in clearly demarcated areas of loss of sensation. Steps. Assess light touch sensation for each branch and ask the patient to say yes if they can feel it. Choose 3 spots to test on each side of the forehead, cheek, and midway along the jaw. Compare left and right. Ignore minor differences as it's difficult to press with exactly the same force each time. Assess pin prick sensation at the same points using a sterile pin. Assessment of temperature sensation is not routinely done. This is tested using specimen tubes or other small containers full of warm or cold water at the same spots as light touch assessment. Consider testing this only if abnormalities in light touch or pinprick are found. The corneal reflex. To test for the corneal reflex, first ask the patient to remove any contact lenses. Ask the patient to look up and away from you. Gently touch the cornea with a whip of cotton wool and bring the cotton from the side so that it cannot be seen approaching. A normal response is a blink. When there is no response, this could be due to ipsilateral cranial nerve V1 palsy. If there is lack of blink on the ipsilateral side only, this could mean that there is a cranial nerve 7 palsy. These are my references. Thank you.